Okay, let's unpack this. I mean, there are few things more alarming than seeing your dog or cat suddenly struggling to move, right? Maybe they can't stand up, back legs aren't working. It's just instantly scary.
It really is. And confusing for owners.
Totally. So today we're taking a deep dive. We want to understand what's actually going on when our pets experience weakness or even full paralysis.
It's something vets deal with a lot, and it definitely involves getting into the nervous system, which can seem complicated.
Yeah, for sure. So our guide today is some really detailed info straight from a veterinary text. Think of this as like a clearer path to understanding the key terms, what might be causing it, how vets even start to figure it out, and what treatment could look like.
Right. The goal is really just to break down a complex subject, make it more understandable for you so you have a better handle on what your vet might be thinking or explaining.
Okay, perfect. So let's jump right in. The absolute basics. What's the real difference between just, say, weakness and actual paralysis? The language seems pretty specific here.
It is, yeah. The source material lays it out clearly. Paresis, P-A-R-E-S-I-S, that's the term for weakness. So the animal can still move the limb, but maybe it's shaky or not as strong.
Okay, so some movement, but not normal.
Exactly. Whereas paralysis, or you might hear the term plegia, P-L-E-G-I-A, that means a complete lack of voluntary movement. They just can't move that limb on their own at all.
Got it. Weakness is paresis, no movement is plegia. And I saw terms like quadri and para used with
So
those.
precisely. It tells you which limbs are affected. So if it's all four limbs, it's quadriparesis or tetraparesis for weakness.
Quadriplegia or tetraplegia for paralysis.
You got it. And if it's just the back legs, the pelvic limbs, then it's paraparesis for weakness.
Then paraplegia for paralysis. Makes sense. Crucial terms.
Definitely. And the source also points out a couple of specific syndromes connected to really severe spinal injuries.
Yeah.
They have very distinct ways they show up.
Oh, yeah. Like what?
Well, one is called Schiff-Sherrington syndrome. This usually happens after some really bad trauma to the spinal cord, specifically below the T2 vertebra, so kind of upper mid-back.
Okay, what does that look like?
It's striking. The animal will be lying down, can't move its back legs at all, they're paralyzed, but the front legs and neck are held out really stiff and straight, like extended.
Ooh. So limp back legs, but weirdly stiff front end.
Exactly. What's happening is the injury lower down cuts off signals that normally inhibit certain reflexes higher up in the neck area, C1, C5. So those front limb reflexes kind of go haywire, causing that rigid posture.
But the front legs themselves aren't actually damaged.
Right. If you test them, the front limb function itself is usually normal. And crucially for prognosis, the source says the animal might still have pain sensation in those paralyzed back legs. That's a really key sign.
Wow, okay, that's incredibly specific. And there was another one mentioned,
Yeah.
spinal shock.
Yes, spinal shock. This is something that happens right after a really severe acute spinal cord injury, often a bit lower down, maybe around the thoracolumbar junction where the ribs end.
And what happens then?
Initially, right after the injury, the paralyzed back legs will actually be aplexic, meaning if you try to test their reflexes, you get nothing. They're completely absent.
No reflexes at all.
At first, yes. But here's the key thing. This changes, and pretty quickly.
How so?
Well, within minutes, or maybe a few hours, the part of the spinal cord below the injury starts to recover from that initial shock or stunning. And because it's now cut off from the brain's usual calming signals.
The signals that normally keep things in check.
Exactly. Without those dampening signals, the local reflexes become hypersensitive. So those same reflexes that were absent just minutes or hours before suddenly become exaggerated or hyperreflexive.
Oh, I see. So the change from no reflexes to overactive reflexes soon after an injury, that pattern itself is a big clue.
It's a classic sign, yeah. It strongly suggests an acute injury in that T3 to L3 spinal cord region, and that the cord is emerging from that initial shock phase.
That's fascinating, just how specific these definitions and syndromes are, and how looking at symptoms, especially reflex changes, already starts giving you clues about where the problem might be. It's like mapping the body's wiring.
It really is. The physical exam is just so fundamental for starting that process.
Speaking of wiring, the source talks about the two main players in making movement happen: the upper motor neuron system, UMN, and the lower motor neuron system, LMN. Can we break that down simply?
Let's try. Think of the UMN system like the headquarters in the brain. It's the CEO that decides, okay, let's move the leg. It initiates the command.
Okay, the decision maker.
Right. And it sends that command down long highways. These are nerve tracks, the source mentions, like the corticospinal tract traveling down the spinal cord. These highways connect to like regional managers in the spinal cord itself.
And those regional managers are the LMNs?
Pretty much, yeah. The LMN system is based in the spinal cord, in specific areas for the front and back limbs. These are the neurons whose wires, the axons, actually go out from the spinal cord, form the peripheral nerves, and connect directly to the muscles.
So they're the ones actually telling the muscle fiber contract?
Exactly. They execute the command. And importantly, they're also responsible for those basic spinal reflexes, the knee-jerk type reactions.
Okay. UMNs in the brain send signals down. LMNs in the cord receive signals and tell muscles to move. Simple enough. So why is checking reflexes such a huge deal for figuring out which system has the problem?
Okay, so here's where it gets really interesting, and it's a key concept. The UMN system, the CEO, normally does more than just send go signals. It also sends signals that sort of refine or dampen the activity of the LMNs. It keeps them in check.
Like putting the brakes on a bit so things aren't too jerky.
Exactly. It provides inhibitory control. So if the UMN system itself or the highway from it gets damaged, those brakes are off. Right. The LMNs down below don't get that calming influence anymore. They become overly excitable, kind of hyperactive on their own. And the result, the spinal reflexes become exaggerated hyperreflexic. Muscle tone might even increase. But the muscle itself usually stays relatively healthy, maybe just mild wasting over a long time.
Okay, so UMN damage, overactive reflexes. What about if the problem is with the LMNs themselves? The regional managers or their wires out to the muscles?
Well, if the LMN system is damaged, then the whole circuit that executes the movement and mediates the reflex arc is broken right there.
So no signal gets through properly.
Correct. Therefore, the reflexes become weak or reduced. That's hyperflexic, or they might be completely absent or flexic. Muscle tone is lost, so the limb feels floppy or flaccid.
Yeah.
And because the nerve isn't stimulating the muscle anymore.
The muscle wastes away.
Yes, and rapidly. You often see severe muscle atrophy or wasting within just 5 to 7 days with LMN damage.
Wow. Okay, so just checking if a reflex is like super jumpy or totally gone tells you fundamentally if the issue is likely higher up in the brain or spinal cord highway, UMN, or down at the level of the nerve going to the muscle, LMN. That's a huge clue.
It's absolutely one of the most powerful parts of the initial neurologic exam for localization. A real aha moment, like you said.
Definitely. All right, so an owner sees their pet is weak or can't move. What are the general signs they might notice, and what does a vet actually do during the exam to start figuring this out?
Well, owners usually report things like their pet suddenly can't get up, or they're stumbling, maybe dragging their back legs. It might happen really fast, acutely, or it could be something that's been getting gradually worse over days or weeks.
Okay.
And sometimes with things that compress the spinal cord, like a disc problem, you might see a progression starts as just being a bit wobbly or uncoordinated, which is called ataxia, then progresses to noticeable weakness, the paresis, and maybe eventually ends up as full paralysis, plegia.
And the general physical exam, apart from the legs.
Often it can be pretty normal unless there's obvious pain somewhere or if the weakness is part of a bigger systemic illness. But the source highlights one really critical thing to check for that isn't neurological but can look just like paralysis.
What's that?
An aortic thromboembolism, or AEE, sometimes called a saddle thrombus in cats. It's basically a blood clot that lodges, usually where the aorta splits to go to the back legs, cutting off blood flow.
Oh, right. And that causes sudden back leg paralysis.
Exactly. Looks very much like acute paraplegia, but the key difference is on the physical exam. The vet will check the femoral pulses, the pulse in the groin area. With an ATE, those pulses will likely be absent or very weak. The back paws might feel cold, and the nail beds could even look bluish.
Because there's no blood flow.
Right. So checking pulses is vital to rule that out early because it's a vascular emergency, not primarily neurological, and needs totally different treatment.
Okay, so rule out the big non-nerve mimic first.
Yeah.
Then comes the neurologic exam itself, which sounds like the real detective work.
It absolutely is. This is where the vet confirms, yes, this is neurological weakness or paralysis, and crucially tries to pinpoint where the lesion is, localize it. And as we mentioned, if the limbs are paralyzed, you have to assume the bladder is too. Loss of voluntary urination is almost always part of the picture.
And the localization that uses those UMN, LMN reflex patterns we talked about, plus which limbs are involved.
Exactly. By carefully checking reflexes, muscle tone, and noting which limbs are affected, front only, back only, all four the vet can follow the clues to narrow down the location of the problem in the spinal cord or even the brain. The source basically gives us a map.
Can you walk us through some examples?
Sure. So If all four limbs are weak or paralyzed tetraparesis or cloustria, and all the reflexes are exaggerated, hyperreflexic,
Yeah.
that points to a problem high up in the neck, in the C1 to C5 spinal cord segments, or potentially even in the brainstem.
Okay. High neck or brain for all four weak with jumpy reflexes. What else?
If all four limbs are weak, but the front limb reflexes are normal, or maybe even reduced, while the back limb reflexes are exaggerated, that pattern suggests the lesion is a bit lower in the neck, in the C6 to T2 segments.
Why that difference?
Because that C6T2 area contains the elements going out to the front limbs, so damaging them directly causes reduced front limb reflexes. But the UMN tracts going through that area down to the hind limbs are also damaged, causing the exaggerated hind limb reflexes.
Ah, okay. So it affects both systems differently depending on location. What if all four limbs are weak and all the reflexes are weak or absent?
That suggests a widespread LMN problem, either something affecting peripheral nerves or muscles throughout the body, or maybe simultaneous problems in both the neck LMN area, C662, and the lower back LMN area, L4S2.
Okay, that covers the all four limb scenarios. What about just the back legs, paraparesis or paraplegia?
Right. If the front legs are totally normal, but the back legs are weak or paralyzed and the reflexes in those back legs are exaggerated, UMN signs, that's the classic picture for a lesion somewhere between T3 and L3 in the spinal cord. That's most of the back region.
T3, L3. Got it. And if the front legs are normal, but the back legs are weak, paralyzed, and the reflexes are reduced or absent, LMN signs.
Then the problem is further down, affecting the LMNs for the hind limbs. So somewhere in the L4 spinal segment down to about S2.
And the source gets even more specific sometimes.
It does. For instance, normal front legs, weak paralyzed back legs, but specifically the knee jerk, the patellar reflex, is depressed. That pinpoints it more precisely to the L4, L6 spinal cord segments.
Right.
Or normal front legs, weak paralyzed back legs, but the patellar reflex is exaggerated, while the withdrawal reflex testing the sciatic nerve is weak. That points a little lower to L6, S2 segments.
That's incredible precision. And what if the legs seem okay for walking, but say the tail is limp, the anus seems loose, and the pet is incontinent?
That usually indicates a problem right at the very end of the spinal cord, around the S2 segment and further back, affecting the specific nerves that control the tail, anal tone, and bladder bowel continence.
You know, connecting this to the bigger picture, it really is remarkable how the body's wiring is so precise. Just by carefully observing how things are working or not working and testing these simple reflexes, vets can often zero in on a very specific location along the spinal cord or in the nervous system, like following a map based on the symptoms.
It's a fantastic example of how structure dictates function, or, in this case, how dysfunction reveals the underlying structure and where it's gone wrong.
So once the vet has a good idea of where the problem is located, what actually causes these issues? The source made it sound like the list of potential causes is, well, huge.
It really is incredibly diverse. The specific cause depends heavily on whether the signs point to an UMN or LMN problem, whether it happens suddenly or gradually, the animal's age, breed. Lots of factors.
Okay, can you give us a feel for the range? Like, what sort of things cause those widespread LMN problems, the ones with weak reflexes everywhere?
Sure. For sudden onset, acute LMN weakness affecting all four limbs, the source lists things like coonhound paralysis, which is actually an immune-mediated nerve inflammation, not just in coonhounds.
Okay.
Botulism, from ingesting a specific toxin. Tick paralysis, caused by neurotoxins from certain types of ticks, or sometimes an acute flare-up of myasthenia gravis, which affects the communication between nerves and muscles.
And if that kind of LMN weakness comes on slowly, gradually?
Then vets think more about chronic conditions. Things like ongoing polyneuropathies diseases affecting multiple nerves, or myopathies, muscle diseases. These could be caused by long-term exposure to toxins, chronic infections, inflammatory conditions, or underlying metabolic issues, like certain endocrine diseases, or even some congenital problems.
Okay, that's a wide range for LMN.
Right.
What about causes for UMN problems, the ones with exaggerated reflexes? Say, just affecting the back legs, paraplegia.
Right, that T3-L3 spinal cord region we talked about. By far the most common cause there, especially in certain breeds, is an intervertebral disc herniation, a slip disc that presses on the spinal cord.
The classic Dawson issue, though it happens in others too.
Exactly. But other causes for UMN paraplegia include things like a fibrocartilaginous embolism, or FCE, where a tiny piece of disc material gets into the blood supply of the cord, causing a sort of spinal stroke.
Okay.
Also, discospondylitis, which is an infection of the vertebrae and the disc, spinal tumors, either primary or spread from elsewhere, significant trauma like fractures,
Mm.
certain congenital malformations, and degenerative myelopathy, an inherited progressive degeneration seen in breeds like German Shepherds.
Wow. Yeah, the list is just incredibly varied. Disc problems, infections, clots, tumors, trauma, inherited stuff. It really drives home how many different ways the nervous system can be affected.
It certainly does.
And you mentioned breeds. The source highlighted specific risk factors, right? Certain conditions are more common in certain types of animals.
Yes, definitely. We mentioned degenerative disc disease being common in dachshunds, poodles, cockers, beagles, those long-backed or chondrodystrophic breeds. Coonhound paralysis, despite the name, often seen in hunting dogs exposed to raccoons, but can occur in any dog.
Okay.
Trauma, obviously, is a higher risk for animals that roam outdoors. There's atlantoxial instability, a problem at the very top of the neck, often seen in toy and small breeds.
Right.
Lumbosacral instability, affecting the low back, is more common in large breeds, especially working dogs like German Shepherds. Wobbler syndrome, another neck issue causing compression, is typical in large and giant breeds like Dobermans and Great Danes.
Lots of large breed neck issues, it seems.
There are several, yeah. And then you have things like syringomyelia fluid cavities in the cord, strongly associated with Cavalier King Charles Spaniels and other small brachycephalic short-nosed breeds. Spinal arachnoid diverticulum, another type of fluid outpouching, seems more common in Rottweilers and pugs.
So breed, age, lifestyle, they all provide important clues for the vet when they're building their list of possibilities.
Absolutely. It helps narrow things down initially.
Okay, so the vet has done the exam, they've localized the lesion, they have a list of likely causes based on the signs and the signalment. How do they actually confirm the specific diagnosis? What's the diagnostic journey look like?
Well, it's a process, usually step by step.
Mm-hmm.
After the exam and localization, they start ruling things out. We already talked about checking femoral pulses to rule out that aortic clot, the ATE. That's critical first step for sudden paraplegia.
Right. What comes next? Lab tests, imaging.
Usually a combination. Basic blood work CBC, chemistry panel, and a urinalysis are pretty standard. Often these might be normal and purely neurological cases, but they're important to screen for underlying systemic illness, inflammation, or infection that could be contributing.
And then more specific tests depending on what they suspect.
Exactly. If they suspect discospondylitis, that spinal infection, they might do a urine culture, maybe blood cultures, looking for bacteria. If myasthenia gravis is on the list, there's a specific blood test for acetylcholine receptor antibodies. If they're thinking muscle inflammation, polymyositis, they might check a muscle enzyme level called CK, creatine kinase. They'll look at red blood cell counts, blood glucose, maybe cardiac tests if heart disease could be playing a role, and sometimes specific titers or tests for infectious agents known to affect the nervous system, like tick-borne diseases, fungal infections, certain viruses or protozoa mentioned in the source.
That covers a lot of lab work. What about seeing the structures themselves? Imaging must be key for spinal issues.
Oh, absolutely crucial. Spinal x-rays, radiographs are often a starting point. They can show obvious things like fractures, dislocations, bone tumors, signs of discospondylitis, or sometimes evidence of disc herniation, like calcified material in the canal.
But x-rays don't show the spinal cord itself very well, right?
Correct. So for a definitive look at the spinal cord and soft tissues, you usually need advanced imaging. MRI is generally considered the gold standard now for spinal cord issues. CT scans can also be very useful, especially for bony detail or acute trauma. These have largely replaced older techniques like myelography.
Where they inject dye around the cord.
Exactly. Myelography is still used sometimes if CT or MRI aren't available, but it has more risks and gives less detail.
Are there other specialized procedures vets might use?
Yes. Collecting cerebrospinal fluid, CSF, the fluid surrounding the brain and spinal cord via a spinal tap, is common, especially if they suspect meningitis or encephalitis, inflammation, or infection within the nervous system. Analyzing the cells and protein in the CSF gives vital clues.
Okay.
For those generalized nerve or muscle disorders, LMN problems, they might do electrodiagnostics like electromyography, EMG to assess muscle electrical activity, or nerve conduction velocity studies to see how fast nerves are sending signals.
And biopsies.
Sometimes, yes. A muscle biopsy or even a nerve biopsy might be needed to diagnose certain types of myopathies or neuropathies. And if imaging suggests discospondylitis, they might do a fine needle aspirate of the disc space to get a sample for culture and cytology.
You know, thinking about this whole process, it really underscores that diagnosis isn't usually just one single test. It's a systematic approach, combining the clues from the exam, the lab results, the imaging, all guided by what the vet suspects, based on the localization. It's real detective work.
It absolutely is. Each piece of information helps rule possibilities out or points more strongly towards a specific underlying cause.
So once that detective work leads to a diagnosis,
Yeah.
what happens next? What does treatment and management actually involve? It sounds like it could be pretty intensive, especially for the severe cases.
Yeah, treatment is completely dependent on the specific diagnosis. There's no single answer. But you're right, for any pet with significant weakness or paralysis, there's some really vital general care that's almost always needed. Initial inpatient care, hospitalization, is often required, especially to get bladder management sorted out.
You've mentioned bladder management a few times. Why is that so critical?
Well, when the nerve signals to the bladder are disrupted by spinal cord injury or disease, the pet loses the ability to urinate voluntarily. The bladder fills up, but they can't empty it.
So it just keeps filling.
Yes. And if it gets overly full and stretched, the bladder muscle itself can be permanently damaged, leading to what's called bladder atony, where it loses its ability to contract even if nerve function returns. Plus, stagnant urine is a perfect breeding ground for infection.
Okay, so it needs to be emptied regularly.
Absolutely. This usually means manually expressing the bladder by gentle squeezing or placing a urinary catheter several times a day, maybe 3 or 4 times. This has to continue until the pet regains function. It's a non-negotiable part of care, whether in the hospital or at home.
That sounds like a huge commitment for the owner if the pet goes home.
It is, definitely, and something owners need to be fully prepared for and trained to do. Other general care includes things like assistance with feeding if needed, restricting activity, especially early on if things like disc herniation or trauma are suspected to prevent making things worse, and starting physical therapy.
Physical therapy is important even if they can't move.
Yes, very important. Passive range of motion exercises help maintain joint flexibility, massage can help with circulation and muscle tone, and other techniques can help stimulate nerves and prevent severe muscle wasting.
And just basic nursing care, like preventing bed sores.
Critical. We call it patient care. This involves keeping the bedding absolutely clean and dry to prevent urine scalding on the skin, which can lead to nasty infections. Using thick, padded bedding helps prevent pressure sores or decubital ulcers, especially over bony spots like hips and elbows. And for animals that can't move at all, quadriplegics, they need to be manually turned or repositioned frequently, maybe every 4 to 6 hours, to prevent sores and also to help prevent lung congestion.
Wow, okay. That's a lot of hands-on care. What about fixing the underlying problem? Is surgery often an option?
Surgery can be the best and sometimes fastest way to improve things for certain conditions, particularly those involving compression of the spinal cord. Think severe disc herniations, spinal fractures, or luxations that need stabilizing, some types of tumors that can be removed, or certain congenital malformations. But it really depends on the specific diagnosis, how severe it is, the overall health of the pet, and the prognosis.
Right, not everything is fixable with surgery. What about medications?
Again, totally depends on the diagnosis. The source mentions corticosteroids like prednisone or dexamethasone. Their use in acute spinal cord injury itself is actually pretty controversial.
Oh, why is that?
Well, while they might help reduce inflammation and maybe some associated pain, there's not strong evidence they significantly speed up the actual recovery of the damaged nerve tissue. They are definitely used for specific inflammatory conditions of the nervous system, though.
So not necessarily a go-to for every paralysis case.
Not automatically, no. And the source makes a point of highlighting some really important precautions and contraindications. You absolutely do not want to use steroids if you suspect an underlying infection like discospondylitis or certain fungal or protozoal infections of the nervous system, because steroids suppress the immune system and can make those infections explode.
Okay, that's crucial.
Also risky if the animal has aspiration pneumonia, which can happen with conditions affecting swallowing like severe LMN disease or myasthenia gravis, because steroids can worsen pneumonia and delay healing, plus potential side effects like stomach ulcers.
So careful consideration needed there. Are there other types of medications used? For pain, maybe?
Yes, pain management is important. Depending on the type of pain, vets might use NSAIDs, non-steroidal anti-inflammatory drugs, often for bone or joint pain associated with spinal issues. The source also lists drugs like tramadol and gabapentin, which are frequently used for neuropathic pain, that nerve-related tingling or burning type of pain that can happen with nerve damage. The choice really depends on the individual case, what other meds they're on, and potential side effects. And of course, for specific diseases, there are specific drugs, like pyridostigmine bromide for myasthenia gravis to help nerve muscle signals, or for tick paralysis, the main treatment is just finding and removing the tick.
Right. So it really hammers home that treatment isn't one size fits all. It's highly tailored to the diagnosis. And managing all those secondary things, the bladder, the skin, mobility, is just as vital as treating the primary disease itself.
Exactly. It's a holistic approach.
And taking care of a pet with paralysis, especially long-term, sounds like a significant undertaking. You mentioned preventing complications. What are the main ones people need to watch out for, according to the source?
Yeah, beyond the neurological problem itself, there's a list of common secondary issues. Urinary tract infections are very common because of the bladder issues we discussed. Bladder atony, where the bladder loses its ability to contract, can happen if it's allowed to get overstretched repeatedly. Urine scalding, skin irritation from urine, and secondary skin infections, pyodisa, are risks if hygiene isn't meticulous. Constipation can be an issue from lack of mobility and nerve dysfunction. And those decubital ulcers, the pressure sores, are a constant concern for pets that aren't moving much.
Those all sound manageable with diligent care, hopefully. Are there more severe, life-threatening risks?
Unfortunately, yes. Aspiration pneumonia is a major one, especially in animals with generalized LMN weakness affecting swallowing, or really any quadriplegic patient who might regurgitate and inhale stomach contents because they can't easily clear their airway.
That sounds serious.
It is. Another devastating complication, though less common, is myelomalacia. This is a progressive softening and death of the spinal cord tissue that can sometimes happen after very severe acute spinal cord trauma or massive disc herniations. It ascends up the cord and is usually fatal once it reaches the nerves controlling breathing.
Oh, wow.
And related to that, respiratory compromise or even paralysis of the breathing muscles can occur with ascending myelomalacia or with severe generalized LMN diseases that affect the diaphragm and intercostal muscles.
That really highlights why close monitoring and intensive care, especially in the early stages after a severe injury or diagnosis, are just so incredibly important.
Absolutely. Catching and managing these potential complications early can make a huge difference to the pet's outcome and their overall quality of life.
So we have covered a lot of ground today, really taking a deep dive, guided by this veterinary source. We started with just defining weakness versus paralysis, those key terms like paresis and plegia.
Then looked at how the UMN and LMN systems work, and crucially, how checking reflexes helps pinpoint where the problem might be.
Right. Then we touched on the huge range of possible causes, from discs to infections to toxins to genetics.
Walked through the diagnostic process, that step-by-step investigation involving exams, labs, and imaging.
And finally, talked about the treatment, which is so specific to the cause, and the really intensive general care and management that's often needed, especially for paralyzed pets.
And pulling directly from the source material really allowed us to get into those specifics, the why behind certain tests or treatments, going a bit deeper than just a quick overview.
Yeah, definitely. And hopefully for you listening, this deep dive gives you a much clearer picture of what's involved when a pet faces these mobility issues. Maybe a better understanding of what your vet is looking for, the questions they're asking, the tests they're running, and honestly, the dedication that care can require.
You know, if we connect this back to the bigger picture, understanding the type of paralysis or weakness, is it UMN, LMN, and knowing precisely where the lesion is located, that localization isn't just like academic trivia for vets, it is the absolute foundation for everything that follows. It dictates the possible causes, guides the diagnostics, informs the treatment options, and ultimately helps predict the prognosis, the likely outcome for recovery. Localization really is key.
It's incredibly powerful how the body tells its story if you know how to read the signs. Which actually leaves me with a final thought for you to maybe mull over. Given how much the physical exam things like reflexes, posture, which limbs are affected, can reveal about a very specific location deep inside the nervous system, like reading this hidden internal map. What other kinds of hidden maps might our own bodies, or the bodies of our pets, hold? What other subtle signs might be telling intricate stories, just waiting for us to learn how to interpret them? Something for you to think about.